just to give everyone a quick introduction. So this is a webinar series by Heal Cycle, which is a community and an app focused on improving women's mental and reproductive health. And the focus specifically right now is on premenstrual mood disorders like PMS, PMDD, which is premenstrual dysphoric disorder, a more severe form of PMS, so to say, also premenstrual exacerbation of underlying mental health conditions. But these premenstrual mood disorders or menstrually related disorders also have overlap or with neurodevelopmental conditions such as autism and ADHD, according to early research. There is a lot more that needs to be studied in this field, but this is what some research in the field has shown. And so this session today will deal with some of that intersection. And if you want to learn more about Heal Cycle, I'll also quickly give an overview. It's an Android and iOS mobile app, and we're about to launch our beta phase. It focuses on symptom tracking, journaling, and community support, as well as providing insights on premenstrual mood disorders. You can visit the website, which is healcycle.com, to learn more. We also have a women's health community, which I will share at the end. Today's session the title is quite long, but it is on PMS, PMDD, but more broadly, the mind-body link in neurodiverse people or people with intellectual and developmental disabilities. And I will quickly introduce our two wonderful speakers who are here giving us their time. Dr. Gerald Nebeker, who has had a 40-year career creating supports for people with intellectual and developmental disabilities. He has 2 doctoral degrees, one in the management of nonprofits and the other in behavioral health, and has spent many years working with and designing behavioral intervention programs for people with IDD. And he understands how paradigms, choice, and mental and physical health affect human behavior. Thank you so much for joining us today, Dr. Nebeker. We also have Angie Templeton, who has worked in the IDD field for 21 years and also holds a master's in applied psychology. Her career has included a focus on serving individuals with complex needs, including medical, mental health, and behavioral aspects. And she has a special interest in working with underserved individuals and populations. Thank you so much for being here, Angie, and I will let you take over.
Great.
Thank you so much.
So again, Angie, I think is going to get the PowerPoint going. Great to be here. I'm Gerald Nebeker. And my pleasure to speak first. So I'm going to talk 2 parts. I'm going to take the first part and talk about trauma choice and mental and physical health. And I'm going to first talk about trauma. So I'm going to go to that next slide. So some of you may be familiar with a study that was completed and actually published in 1998, which is commonly referred to as the CDC Kaiser ACE study. In short, Kaiser Permanente is a large healthcare provider in Southern California, or in California, in America, and it surveyed 17,000 of their members. And they did that in 2 different batches. They did it in 1995 and 1997. They found that 61% of adults had at least one adverse childhood experience, or ACE, and 16% had 4 or more. And these are the ACEs that they identified: physical abuse, sexual abuse, emotional abuse, physical neglect, emotional neglect, parental mental illness, parental substance dependence, incarceration of a parent, parental separation or divorce, domestic violence, bullying, community violence, neighborhood safety, racism, and living in foster care. Next slide. Now, ACEs in India According to the Rajiv Gandhi National Institute of Youth Development, no nationwide study exists on the prevalence of ACEs in India, at least that I could find. The limited research that I've done on ACEs in India identifies a similar list as the CDC Kaiser study, adding a couple, added poverty, child labor, and street begging, and noting that socioeconomic factors and cultural norms exacerbate them. From the American studies, it's found that 4 or more ACEs are associated with an increased likelihood of mental health issues like depression, substance abuse, suicide attempts, chronic physical diseases like heart disease, stroke, cancer, and diabetes, as well as risky behaviors like smoking and physical inactivity as adults, which is an interesting thing that early trauma can affect both the physical and mental health of people when they get to be adults. From studies in America, 82% of people with intellectual and developmental disabilities, or IDD, have had at least one ACE, and 20% had 4 or more. So the incident of ACEs occurring in people that are neurodiverse or IDD is much higher than just the normal population. Individuals with IDD are more susceptible to experiencing trauma like physical, emotional, or sexual abuse, neglect, and exposure to violence compared to the general population due to their vulnerabilities and communication and understanding. Trauma can significantly contribute to the development of challenging behaviors in people in IDD, as it can lead to difficulties regulating emotions, coping, and stress, and understanding social cues. Oftentimes, the people with IDD can't express with words what they're feeling, and so they just simply have to act out some of those. And I'll give you some examples of that as we get into this. Like I said, individuals with IDD may struggle to effectively communicate their needs and distresses, leading to behaviors like tantrums or self-injurious behaviors as a way to communicate. Sometimes challenging behaviors in people with IDD might be attributed solely to their disability, potentially overlooking underlying trauma and the need for targeted interventions. Behaviors that are linked to ACEs in individuals with IDD include aggression towards others, self-injurious behavior, property destruction, repetitive behaviors like stimming, withdrawal, and extreme anxiety. And I've seen all of those in people with IDD. I'm going to talk a little bit about paradigms. Paradigms are our belief systems. Our paradigms are a key filter for viewing and interpreting the world. They are central in faith healing, for example. If you believe your doctor, priest, or shaman can cure you, they just might. I'm going to give you an example of Colin. Colin was a Native American living in the state of Utah in the United States. He was someone that we supplied supports to, and we had him working on a crew that did landscaping many years ago, and he mowed lawns. Colin was fairly mildly intellectually disabled. At any rate, Colin one day was mowing and hit a snake. And in his culture and his belief system, or his paradigm, if you will, killing a snake was a bad thing. And Colin immediately started exhibiting aggressive and violent behavior. He started striking out and hitting people, and which continued, even though staff reassured him that everything was going to be okay, that it was an accident. He continued his aggressive behavior. My background as a behaviorist, the first thing I thought of was, well, let's create a behavioral program for him and reward the positive behaviors and maybe consequent the negative ones. And that's something that we typically do, is we just engage in that without considering a person's disabilities paradigms or that belief system. Rather than that, we arranged for a medicine man to do what's called a sing, or a curative ceremony. So we paid a medicine man to work with Colin, and he did a sing and essentially vanquished the evil spirits that Colin believed had entered his body. And with that, all of those antisocial behaviors, that negativity, left immediately. We didn't need to do a behavioral plan. We just needed to treat Colin in a way that was respectful of his belief system. Use someone that was that he thought was had that ability to vanquish those evil spirits, and it worked. It worked great. All right, next slide. But so if you've not read this book, I highly recommend it. I've recommended this book to everybody that I could see, mostly because it's a little different than you think. It's called The Lost Art of Healing. It's a wonderful book by Dr. Bernard Lone. It contains many stories about the interplay between belief systems and healing. He was I think he was a Nobel Prize winning man, Harvard heart doc. He went to China on the cultural exchange when Nixon did that many, many years ago. But it's a wonderful book, and I'd highly recommend it. All right, next one. So choice. Choice is not typically talked about enough in behavioral health circles. And I'm fascinated by it because I've seen people change their lives and their self-destructive behaviors overnight simply by deciding to do so without any intervention. One example of this sudden shift was a client named Bob. So Bob came to one of my programs from the police. He had assaulted someone in his group home and was going down the street with a tire iron, breaking windows out of cars. He had hurt a dog. Anyway, the police picked him up. He ripped the car door off the police car, which is pretty hard to do. Any rate, we worked with Bob for many years, and he's probably, I mean, he was big, he was angry, he was strong. He's the only person I've ever met that could rip a toilet, a USA toilet, out of the floor and throw it at you. He also had a behavior that made it very difficult for him to assimilate in the community. He liked to wear women's underwear outside of his clothing. And I don't think it was as much of I think it was an act of defiance or maybe attention getting as opposed to like a sexual fetish. But the interesting thing with Bob is if the staff tried to correct that behavior by saying, hey, Bob, you might not want to wear that out in public, one of two things would happen. He'd either break their nose or their arm. And yes, he did break staff's noses and arms. He was a hard person. Fast forward, Bob continued, we were able to shape it a little bit, but not much with behavioral intervention. Then one day, all on his own, Bob announced to the staff, I'm done with all that. And he was, and he never did it again. So no behavioral intervention. Bob simply made the choice to stop acting like that. And he just stopped. In fact, the interesting thing is he's probably the only client that I have ever worked with who graduated out of federal funded programs. He didn't need them anymore. And now he got married and he's working in a competitive job in the community. So no behavioral intervention happened with Bob. It was simply his choice to do something different. All right, next slide. So I've been fascinated by this and I've been researching this phenomenon and excuse the shameless plug, but I'm creating a podcast about it. It's called The Click, and I hope that I could launch that in 3 months because I have several stories of people like Bob that have developmental disabilities, as well as other people that don't, that have just changed their lives with just by deciding to do so. Next slide. Mental and physical health integration, and this is an interesting thing. You can go to the next slide. So with people with IDD, it's often easy to diagnose a physical ailment. That's easy. You can simply give a blood test or do an ultrasound. They do not require a conversation to diagnose an issue. Mental illness can be much more difficult. There's no reason to assume that the same mental illnesses that occur in the general population don't occur in people in the IDD population, and perhaps more so because of the increased likelihood of trauma throughout the person with IDD's life. Just because the person cannot speak doesn't mean they aren't depressed or anxious. And because they tantrum and hit in the morning might not mean they are angry, but simply communicating that they are in pain from their rheumatoid arthritis, for example. And I have a classic example of that. Many years ago, I worked with a person that every morning he would get up and hit somebody. And the staff said, well, we need to do a behavioral program with him. So the first question I asked is, tell me about the medical conditions that this person has. And they said, well, he's got arthritis. Okay, so how does a person with arthritis feel when they get up in the morning? Well, they hurt and they might be angry. And so basically, instead of a behavioral intervention program, we treated his arthritis, and guess what? Magically, all the behaviors disappeared because he was being treated. Now, he couldn't communicate. He had some profound intellectual disabilities. The only way he could communicate is to get people's attention by striking out. Anyway, and we often don't think of that too often when we work with people with disabilities. We just assume that there's some other motivation. All right, next slide, which I think is my conclusion. So I briefly reviewed how trauma, paradigms, choice, and the interplay of mental and physical health can affect people generally, and people with IDD specifically. Primarily, caregivers are the key to identifying changes in the behavior of people with IDD, and often that is the only way of knowing something is wrong. It takes intimate knowledge of the person's skills and time to determine if that change was from ACEs, cumulative effects, early on, the person's paradigm, their choice, or a mental or physical condition. Finding out the real cause is the gateway to more effective treatment. Anyway, thanks for your time, and I believe it's your turn, Angie.
Yep.
Yeah, I think we can also take a quick pause if anyone so far has any questions on what Gerald presented on topics of ACEs and paradigms, choices. What was the last one that I'm missing? Mental and physical health integration. So I know we have some professionals from different backgrounds who are attending this webinar. So if you've seen this in your own practice or you're curious about any of these topics, please feel free to unmute yourself or ask a question in the chat. Okay, so we don't have any questions yet, so I think we can move on. But if anything comes up, feel free to put it in the chat and we will take those questions.
Hi, I'm Angie Templeton, and I will be taking over for part 2. And in this section, we're going to dive a little bit more deeply into diagnostic overshadowing for people with IDD. We're going to talk about some women's health perspectives and also review basic health tracking options that can help support positive health outcomes. And Dr. Nebeker gave a great overview of mind-body connections to help get us started. So let's talk a little more about diagnostic overshadowing. So this is basically a cognitive bias that involves a medical or mental health professional attributing observed symptoms to a known existing disability, illness, or disorder instead of considering that they may come from a separate comorbid condition. So this can unintentionally result in diagnoses being missed and patients failing to receive effective treatment. When we think about disabilities, the Joint Commission did a 2022 study and concluded that individuals with disabilities are at greater risk, sometimes significantly greater risk, of being affected by diagnostic overshadowing than people without disabilities. They also experience increased overall health risks that include even shorter life expectations as a result of this and other factors. A notable example is that pregnant women with disabilities have a significantly higher risk of serious pregnancy and birth-related complications that includes maternal death than women without disabilities. So this is really significant to consider. So when we focus on India, there was a study published in 2019 in the Journal of Psychiatry, Indian Journal of Psychiatry by Kipshore et al. That told us that even though people with IDD are 3 to 5 times more likely to experience psychiatric illness than people without, diagnostic overshadowing can cause these conditions to be underreported, misdiagnosed, and also undertreated. And an additional consideration was that there are some limitations in structured diagnostic interviews that can create further barriers to achieving these accurate diagnoses. And that's significant because sometimes the structured interviews need to change a little bit to capture information that may be presented a little bit differently for people with IDD. They may need to hear things a little bit differently. There may be some different presentations of symptoms associated with common and uncommon conditions. So that's of significance. Physician training is an aspect of this that most physicians don't receive a lot of training on working with people with IDD in their practice. And there are so many individual differences that one of my favorite sayings in autism is, if you've met one person with autism, you've met one person with autism, because there can be very, very different presentations. And so it can be really difficult for physicians to have limited interactions, not really get to know an individual, and now they're in charge of their medical care. So sometimes things can be missed, and sometimes they're not really sure what steps to take to be able to capture all of the information that they need and even communicate with people with IDD at times who may have limited means of communication. The good news is that effective advocates can be very, very helpful in these scenarios. So I want to tell you an example about a young woman I worked with who I'm going to call Renee. So Renee was diagnosed with autism, and she was what we call a non-traditional communicator. She made noises but did not speak words, and she had limited functional communication skills. So she had a picture communication system but was still learning how to utilize that effectively, and there were very limited choices that she could make as we worked to expand her vocabulary. And so her staff members noticed that she was sitting on the floor and rocking back and forth, and she was clutching her abdomen. And that was not typical for Renee. She was a pretty active lady. She was also seen to have intermittent tears coming from her eyes. And so we thought she was probably in pain. So staff called me and they asked what to do. Is it a behavior? Is it medical? And I said, take her to the ER. This is highly unusual behavior. We need to rule out any potential medical causes. So they took her to the emergency room where she was evaluated briefly, and the emergency physician concluded that she has autism, and people with autism can rock back and forth repetitively at times. And so staff members said, this is a change for her. We're really concerned that something's happening in her abdominal region. And the doctor said, I think she's okay, and discharged her. Staff asked for tests to be run, and he did not think that they were clinically indicated at that time. So staff called me back very frustrated and asked me what to do. And I said, take her to a different emergency room. We need to get this sorted out. And there was an emergency room about an hour away, about an hour and a half actually, that was known for working really well with people with IDD. So she went there, but the emergency room notes from the very recent visit were immediately available in the hospital system. So the next hospital assigned a psychiatrist to come in and evaluate Renee, and he was very confused about what was happening. So he gave me a call, and I talked with him about the changes in behavior, that staff was concerned that she seemed to be in pain, and I would agree. And I talked about being really concerned that Renee's diet was a bit restricted based on what she was willing to eat. And she ate very large quantities of cheese, which can sometimes lead to constipation, which in serious cases can lead to impaction. And so I talked about being concerned about that, and he said, that sounds reasonable. And so we ended up talking through what his plan was. And he said that he was going to first do an abdominal x-ray to just make sure that she was okay. So at that point, he facilitated the x-ray, and the results came back immediately that she did have impaction and she needed treatment right away. So he was able to facilitate that, and he let me know what the plan was. And he also said that he would be going ahead and calling the previous emergency physician to let that individual know what the outcome was. The psychiatrist said that he saw a lot with people with IDD, that things could be missed and explained as a manifestation or a symptom of their disability. And so fortunately, because of Renee's wonderful staff members, we were able to get her the care and treatment that she needed, and she was back to herself in no time. Let's talk a little bit more about women's health issues. So one thing that's important to consider in healthcare is that gender bias can enter the equation sometimes. And gender bias can be implicit or explicit. Implicit biases are unconscious, explicit biases are conscious, and both involve attitudes or prejudice about a specific group. And they can affect the person experiencing that bias, their thoughts, feelings, and behavior. And a lot of times, the types of biases we see in healthcare can be implicit. So they're harder to identify. The person experiencing them isn't aware of them, and they can impact health outcomes. So beyond the individual level, gender bias can also present at interpersonal, institutional, and system levels in healthcare. And that means that the effects can be observed in everything from patient-physician interactions to a hospital's policy that ends up creating, and it's often unintentional, but unequal access to healthcare based on demographic characteristics, and that can be seen with an entire healthcare system. So based on the available data, gender biases in healthcare are very prevalent throughout the world. And there's a lot of research that focuses on health outcomes as well as different treatment processes to create these analyses. And many of the consequences tend to disadvantage women. And so data does suggest that the United States and India both experience gender-based health inequities, which is important to think about. The specific consequences of these biases depend on a lot of different factors. So that can be geographical or regional differences, regulatory content, so different rules and regulations that are going to affect different systems, cultural aspects, and socioeconomic status, just to name a few. And these biases can be difficult to counteract. Patients and advocates can take a lot of proactive steps to really help their case. One of the things that can be done is to prepare in advance for appointments. This has been one of the most effective strategies that I've used to assist people with disabilities or people who may otherwise be disadvantaged in accessing appropriate medical care. And you want it to be as objective as possible, but you can bring a data summary of relevant information or potentially relevant information if we aren't sure, that's applicable to what the person is being seen for. It can be helpful to create a list of symptoms and a timeline. When did it begin? How long has it been happening? Point out any patterns. Are there certain times when the symptoms are better or worse? Are there cyclical components? Are there strategies that make the symptoms worse or better? Have there been any changes to frequency, intensity, and duration? Are there any potentially relevant contextual factors? So has a person begun or stopped a medication? Was there a major life event? Because we're again thinking of those mind-body connections, anything that may potentially be relevant. Be as informed as possible. Be respectful and collaborative, but still advocate. Consider a second opinion or referral to a specialist if needed, and actively engage in discussions with the provider throughout the diagnostic process. An important aspect of that I think has been one of the most powerful tools that I've used is to tell the story. And I think Gerald made some good points as he was giving examples that the story can be really powerful in our ability to learn new information and to really connect to that. And the same is true when you're providing advocacy for an individual. It can be helpful for healthcare providers to understand what the person is going through, how they're impacted. And when you make that human level connection, you can more actively at times engage the healthcare provider in really taking an interest in helping solve the problems with the individual that they're seeing. So the story can be very powerful for inspiring people to provide assistance. Let's talk a little bit about premenstrual dysphoric disorder. An overview was given prior to the beginning of our PowerPoint presentation that I think was really great. But it's a condition where symptoms present about a week before the onset of a menstrual cycle. And symptoms can include things like depressed mood, anxiety, difficulty concentrating. People can be lethargic, not have a lot of energy. And there can be changes in sleep, among other things. The effects of PMDD do create clinically significant distress in major life domains that can cause affective, somatic, so pertaining to your body, and cognitive changes. Useful treatments are available that can help improve quality of life for women who experience PMDD, so it's important to recognize it. Unfortunately, the disorder can be under-recognized as well as underdiagnosed. So looking at India in particular, according to a study in 2024, there isn't a uniform measure for PMDD that's standardized for women in India, despite what are anticipated to be high prevalence rates. However, there is an assessment scale that is being developed currently and evaluated that is specific to women in India. The scale is called the Premenstrual Dysphoric Disorder Assessment Scale, or PMDD-AS. So that is exciting progress that sounds like it's being made. Let's talk a little bit about disability intersections. So one of the things that's important to consider for women's health issues and other types of health issues that people with disabilities experience is that the way that the disorder is expressed, the symptoms and the person's changes in their behavior and other aspects can look different. Gerald mentioned communication difficulties, which absolutely applies. And sometimes we can even see most of the symptoms looking like behavior. And I want to give you an example of a woman that I'm going to call Sarah. So Sarah is an individual I worked with who is a non-traditional or nonverbal communicator. She does use an electronic communication system and has a pretty decent vocabulary with that, but she's unable to identify pain for herself, and she certainly can't communicate that to others. It's not something that she's able to recognize and communicate. So we're looking at other types of information that we can glean to tell us if she's in pain or experiencing problems. And so one of the things that Sarah experiences is self-injurious behavior that's fairly intense. And something that we noticed when we began supporting Sarah was that her self-injurious behavior increased about a week before the onset of her menstrual cycle. And she also seemed more agitated and restless. She wouldn't sit still. She was not happy with any of the activities that she was selecting on her communication system. And so she would cycle from activity to activity to activity and just seemed restless. And so we talked with her parents, who gave us good information about this being a pattern. And we all suspected that she was in pain due to her menstrual cycle, that was something she was experiencing. So we were able to talk with her medical providers and get a standing order to give her pain medication that was very simple pain medication about a week before her menstrual cycle, leading until the symptoms were able to subside. And that significantly decreased those spikes in challenging behavior that we were seeing. And so that was not easy to recognize in a medical setting, and really took people knowledgeable about her collaborating and really trying to figure out what was going on, and then helping her access effective treatment. So with that in mind, let's talk a little bit about simple health tracking strategies that can be used also to help prepare for appointments. But this is a really good way to help improve health outcomes by providing good, relevant information to the care providers who are trying to make the diagnosis and developing treatment plans. So objective health tracking can be very helpful for that diagnostic process and getting that effective treatment. It can be completed for behaviors, symptoms of medical or mental health conditions, and significant medical or mental health events. Meaningful tracking can be really complex, and it may involve even electronic systems that are designed for health tracking, or it can be very simple and just involve pen and a paper. It can be done either way and still be useful. So in the next slides, we're going to take a look at some examples of simple tracking that can be completed just as available depending on the tools that people have to utilize. Sleep tracking can be important, and it can be configured for individuals based on their presentations and needs. So it can look different from one person to the next. Some categories that could be included might be time to bed, time up, awake and asleep, appearance of restful sleep or restless sleep, times up to use the bathroom or incontinence, symptoms of nightmares or night terrors, night sweats, etc. And so this can be useful for medical conditions, but also mental health conditions. For example, bipolar disorder is something that can affect awake sleep cycles, and a psychiatrist, for example, may request sleep tracking to help them just really have the best information possible to know the individual's status that they can then use to inform their treatment plan. Behavior tracking can also be configured based on individuals' needs. This can be highly individualized and can take many different forms. So examples of common tracking items can include a type, the type and description of a behavior defined for consistent measurement. We might call that an operational definition of behavior, but the gist is we want a clear description so everyone measures it in the same way. Behavior counts, time of behavior. So an example would be when the behavior occurred, or if it's a very frequent behavior, it might be time intervals and you're just doing counts of a specific behavior type. And it could be maybe a 1 hour block of time and you're counting every time it occurs in that, or maybe it's a 3 hour block of time. Frequency, how often is it happening? Intensity, how severe is it? Duration, how long does it last? Injury to self or others. Interventions attempted, and what was the response? Events before significant behaviors, what led to that? Events after significant behaviors, how's the person's recovery? Are they processing it? Are they saying anything significant that may help us with future similar events? Who observe the behavior, and any notes that are relevant. Maybe we have a new medication. Maybe there's the onset of the menstrual cycle. Maybe there is a visit with a particular individual. Maybe there's a trauma anniversary, things like that. So behavior tracking, as I talked about, is associated with mental health conditions, but it can also be used with behavior support plans and their development. If we're looking at systematically changing our behavior in the environment to help an individual reduce challenging behavior and increase positive behavior, if we're looking at reinforcement plans, things like that, this data can be very, very helpful in addition to working with medical and mental health providers. And changes in an individual's baseline can be a symptom of a mental health condition, but also a symptom of a medical condition. And so I want to give you some examples of what that can look like. The one I want to give you right now is an individual, this is a child, was experiencing some urination outside of the bathroom, specifically in his bedroom. And staff members, I happened to be visiting a program, were telling me about this, and they said, oh, he has this new behavior, and it's really concerning. We think it's intentional. And I said, when has he last been to the doctor? And it had been about a month. And so I had them taken to urgent care because we needed to rule out medical conditions before we could say it was a behavior. And lo and behold, he actually had a urinary tract infection. He just did not express it in a way that his staff members understood. So we're able to get that treated for him and the behavior cleared up, and we were able to do the right thing for him. So I also want to talk about a gentleman I'm going to call Edward. Edward has autism and has limited ability to express himself, including his needs, wants, and concerns. Edward had a new behavior pop up where he started biting the arms of staff. And this was very upsetting to staff, as you might imagine. And our first thing that we did was provide staff with a protective equipment. There were Kevlar sleeves we could put on their arms so that would be bite proof. And then we had kind of like an arm guard. It's a padded sleeve they were able to put over that to protect their arms. And we held a team meeting to talk about what was happening and exploring our follow-up options. And we determined that we would get him into his primary care doctor for a physical and the dentist, because he had a medical condition where he was more susceptible to dental ailments, though he had been to the dentist recently. I think it had been like about 3 months before. And when he went for his dental evaluation after his physical was clear, nothing was noted, they found that he had a lot of cavities and he was probably in pain. And so those were addressed and the biting stopped. So that was another situation where it could have been looked at as a new behavior that someone might be thinking about mental health, other aspects, and we ended up having a medical condition due to his dental health. So it is important to explore all options. So other types of simple tracking would be witness written descriptions of health events, so shaking, unresponsiveness, things like that, for something like a suspected seizure, as detailed and objective as possible. You might want to record menses onset, any indications of blood in the stool, any episodes of fainting or something that looks like pre-fainting, things like that. Photographs of visible symptoms like a rash or something with permission and avoiding sensitive areas. Things might be like skin discoloration as well. We talked about rashes, even injuries. Maybe there's self-injury, maybe there is excessive bruising that may indicate a medical condition, such as a bleeding disorder or something like that. We're wanting to basically capture snapshots in time of symptoms that a physician may not see in their clinical setting quite yet. Health measurements like vitals, heart rate, blood pressure, height, weight, blood glucose, injuries, including you can even track injuries through to healing if that's something that's relevant for the person. And we are on to the conclusion. So we've taken a look at diagnostic overshadowing and biases that can impact health outcomes, including gender bias. Examples of proactive symptom behavior and event tracking that can help facilitate more positive health outcomes for patient-physician interaction level. And the one thing I would say is the most important thing to take away, if you take one thing away from my part of the presentation, is that it's so essential for caregivers to remain informed and aware, because caregivers and advocates can absolutely make all of the difference for people with IDD or people in need of an advocate in general. Okay, actually I'm going to show you my references first. So if anyone is interested in some of the citations we've had for some of the journal articles, I'm going to leave this up for a minute, and then we're going to move to questions. Okay. I think it's time for questions, so I'm going to return to the audience view.
Feel free to also put any question in the chat if you don't want to unmute yourself. You can also raise your hand or just unmute and go. But I did have a question to start us off, I guess. So you mentioned at the end that caregivers should be aware and informed. And I was just wondering if you also had any other like tips for caregivers who might not be like family members, who might be friends instead, or just any like tips or strategies for that.
Sure. Would you like me to take this one? Okay. So for friends and any advocate in maybe a non-traditional role, I would say that relationship that you have with the individual is going to be the key to everything. And if they're asking you for assistance, that means you're in a trusted position and that you're seen as a caring person. So extra points for you for basically being appointed for by someone in need for that role. But I think it's really important to talk with the person about what they want from you, because it can be easy to go into more of a professional role. But when you're in that non-traditional role and have a different type of relationship, it's really important to make sure that you guys have the same understanding of what is expected and what they want from you. And I've actually been in that role for other people as well. And I always have a discussion about, what can I do to support you? What would you like my role to be? Do you want me to be a note taker? And I might help them prepare their own list of questions, and then say, if you forget one of the questions, what do you want me to do? And so really rehearsing what that's going to look like, so there aren't any intentional boundary crossings that can be challenging for a relationship, I think can be really helpful. And I really like to ask the person, to the extent that they're able to communicate what they're looking for, because sometimes my idea is not the same as theirs, and I'm always going to default to what they're comfortable with. Oh, that's a great question.
Should I read it out loud for you, for everyone? So it says, many doctors in my experience are not yet educated on PMDD, which is premenstrual dysphoric disorder.
Mm-hmm.
Do you have any advice on having the conversation with a doctor who may not yet be educated on it, so you can advocate for yourself but not dismiss them as your doctor? And I think this can also
Mm-hmm.
apply for other conditions where you feel like you know something
Mm-hmm.
that your doctor doesn't acknowledge.
Mm-hmm. Yeah, so part of this is going to depend on what you're comfortable with, and also the type of personality you're working with your physician, and that relationship. Something that I've found helpful, because I have run into this, is that I might myself, or helping someone prepare for their own appointment, come with literature and a list of really concise concerns, with saying, you're the medical expert, and, I'm coming to you for assistance, but I'm concerned about whether or not this particular disorder, so premenstrual dysphoric disorder, may be playing into some of the things that I or someone else could be experiencing. And so, in looking into this myself, as I'm trying to make sense of this, I've noted that these things are going on, and that seems to match the diagnostic criteria. What are your thoughts? And if you think that they're maybe not able to have any of that information, if maybe they're not even familiar with the diagnostic criteria, I might print it out and not be confrontational about it, but just ask, and maybe put little check boxes by what may apply, and then have a conversation. So I think you can do that respectfully, but still be a strong advocate, because I really feel for medical and mental health professionals, because there are so many different complexities and presentations, and it's hard to know everything. I don't think anybody is able to know everything. And so the more we can partner with the people who are treating ourselves, and the people that we may be advocating for, I think the better off we are. Does that help?
I'd like to add a little bit to that, and it might be a little more fatalistic, but if your doc doesn't listen to you, find another doc if you can, especially maybe find a woman that's your physician. I don't know that men actually get it. And so, in all honesty, that if you have a physician that will listen to you, wonderful. I know that some physicians are wary of patients that Google their diagnosis and then come in and tell them how to treat it. And that can be a problem. So finding that physician that will listen to you, and in this case, with PMDD, it might be another woman, frankly. So that sounds pretty fatalistic, but and you may not have that luxury. Not that may not be a possibility, but if you do, then I know there's a great difference in physicians and how they care for their patients.
Yeah, and I think that's absolutely true, which is kind of why I started with it depends on the personality you're working with, and Gerald's absolutely right that sometimes if you do come with information that's received well by some physicians and not by others, and it can be a difficult balance. So I think it's also continuing to assess where you're at and how they're responding to you and being able to navigate from there and not being afraid to make a different decision or even ask for a referral to a specialist might be another way to go, or a second opinion. So I think those tools can be utilized as available as well.
Thank you. Do we have any other questions? I know that we also have some psychologists and mental health professionals, so I'm curious if you have anything specifically for them as like advice or tips based on like the cases or examples that we've gone over. Okay.
So you're asking that question of us, advice for mental health professionals?
We actually have another question in the chat, which we can go with. It's directed to you, Dr. Nebeker. What vision do you have for the future of mental health services regarding ACEs and childhood trauma?
The good thing is that trauma is more recognized now than before. I think the ACEs study, although it's been criticized because it's, even though there were a lot of people, 17,000 people, it was basically in California in the United States with a bunch of white people. How that affects the rest of the world and the ACEs, probably they're similar, but maybe not. But at least it created and opened the door for considering the consequences of early trauma. That's being discussed a lot more, being talked about in the mental health arena. That you're trauma informed. There's a whole thing about that now in counseling, as you're probably aware, and it's becoming now more of a thing for people with IDD to recognize that traumas affect for people that maybe not be able to communicate and how to work with that. So, at any rate, I think it's just going to continue to grow and to be considered as more people know about it. I would say if you, as a therapist, if you don't know about it, you should, and physicians should know about it. Caregivers should know about that, the effect of trauma. So my vision would be just to further expanding of that knowledge, because I think it is critically important to know that effect. And golly, I've been doing this for a very long time, and this piece really is fairly recent in the last handful of years in my career to even think about. And so I'm excited about it, because then we can actually address what the problem is, as opposed to just putting Band-Aids on it. I think there was another question.
Yeah, we do have another question for Angie, which is, I heard that Angie has experience with autistic patients. I was wondering if you have some suggestions for how to behave with an autistic teenager who is in a school group. He usually believes all the mean things that other students say about him and gets angry. Do you have some methods so that we can calm him, or other advice? Thank you.
Sure, and I can give a response, and Dr. Nebeker also has quite a bit of experience with people with autism, so we'll invite him to respond as well. But it really depends on the individual and the situation, but I think some generalized things that could potentially be applicable would be that, well, teenagers are very challenging in general, and those school dynamics can be particularly challenging. I think that self-esteem is really important, and having positive experiences. Something that we've utilized for similar situations that's been helpful is talking through with the individual some other perspectives that they might not be thinking about. What might the other individual be going through? And sometimes the issue is that they're going through some challenges themselves, and they're just being mean to people because it's coming out in different ways. And so looking at different things that may be causing that, I think can be helpful to help the individual look at things more holistically that they're not able to do. And something with autism that is a factor, I believe, here is just the difficulty recognizing social cues. And so helping with that can be assistive as well. I have seen times where someone with autism may take something extremely offensively that maybe wasn't meant that way, or the reverse I've seen as well, that it just sort of rolls off when other people might be a little bit more offended. And so I think helping with that perspective taking, I think always helping with self-esteem and reminding people of how many people care about them, reminding people of all the wonderful things about them. I've literally sat down with people and developed a list of everything that they like about themselves. And I add to it quite liberally to make sure that we're rounding it out. I've invited staff to, or advocates or family members to contribute to that. And sometimes it can be helpful to look back at that list and be like, hey, I've got my people and they really care about me, and just being able to buffer some of that and maybe build a little bit of resilience. I think therapy can be really helpful for people who are dealing with self-esteem challenges and those types of things as well. Dr. Nebeker?
Yeah. My thought went immediately to sometimes you may not be able to impact the person themselves much, but you might be able to impact their environment. And by creating an advocate for them in the school system, for instance, or way that maybe they can find a safe place or a harbor or isolation. You can't always control what's going to happen to them, and kids can be very mean, and but you might not be able to help the person themselves deal with that so much, but you might be able to curb some of that negative peer interaction by just advocacy. I used to do, when I was in the school system, do social groups and to educate and pair socially isolated kids with more popular kids, and that was reasonably successful. You can only do the best that you can do, right? And so but to have it in mind and to try to figure out a way to help and intervene is helpful. A lot of times I've seen schools that kind of want to just sweep that under, but just having it at the top of mind is very, very helpful. At least you can look for those things. And sometimes they may find an advocate. Sometimes a person that's on the autism spectrum doesn't want a friend. And so that's where you might have to do the external buffering for them so that they're at least less of a target than they were previously.
Yeah, and I did miss one of the parts. I just read through the question again and usually gets angry. I think teaching skills for how to channel that emotion in a way that's more positive for sort of anger management, if you will, can also be very helpful. What do you do with your body when it's so agitated? Can you take a walk? And that might be working with the school system too, that they are supporting the implementation of these strategies to prevent escalations that may be occurring in the school as well, if that's happening.
All right. I know a couple of people just joined while we were doing the Q&A. So if anyone who just joined has any questions, or anyone else, we are a few minutes over time. So it's okay if people have to head out, but we can take one or two last questions if anyone has any. Okay, thank you. All right, I think that was it. And if people want to stay connected, let me just quickly share some information. So Dr. Nebeker's podcast that will come out, it's called The Click, right? Yeah, and if you want to stay in touch for updates about more events like this, you can sign up at healcycle.com or on Instagram at healcycle. And you can also scan this QR code, or there is a link in the chat to join the WhatsApp community that we run for women's health and related and mental health. Okay, so we have some thank yous in the chat. Thank you so much, guys, for joining. I hope this was helpful for you, and thank you to Dr. Nebeker and Angie again for being such wonderful speakers and for such an informative session.
Thank you. Have a great rest of your evening, I guess, if you're in India, and day and if you're in the United States.
Yeah, we hope it was helpful. Thank you so much for sharing your time with us.
All right. Okay, we have a raised hand. Maybe that was a mistake. All right. Thank you, everyone. I will now end this call, and you can stay in touch with us. The details are on the screen.